All right, well, thank you, everyone. Thanks for joining this afternoon for another session on point-of-care ultrasound. I'm super, super excited to be able to moderate this session. My name is Sarah Nickrivan. I am a Vice Chair of Education and Professor at the University of Washington in Seattle. And we have an amazing panel this afternoon for all of you. We're going to start first with Dr. Rachel Kadar, who's an assistant professor and director of point-of-care ultrasound education at Northwestern in Chicago. Dr. Kadar has a really cool background. She's coming to us having been trained in emergency medicine and critical care, and actually works in the community for about 80% of her time in critical care, but leads the education in point-of-care ultrasound for the Department of Anesthesia at Northwest with the other 20% of her time. So without any further ado, Dr. Kadar.
Thank you very much. So today I'm going to be talking about POCUS and cardiac arrest and undifferentiated shock states. I have no disclosures. So today we'll review some protocols in point-of-care ultrasound, also known as POCUS. Specifically, we will talk about the rush exam, which is the rapid ultrasound for shock and hypotension. We'll talk about POCUS and cardiac arrest, and then we will end with echocardiographic assessment using subxiphoid only view and advanced life support, or EZ-ALS. I know this is a busy slide. It's just to show you that there are many POCUS protocols that are available. The two listed at the top that are in bold are some of my favorites: RUSH, the rapid ultrasound for shock and hypotension, and the EZ echocardiographic assessment using subxiphoid only. I think it's more important that you have a systematic approach when you're going to the bedside to evaluate your patient who's hypotensive than it is which protocol you use, but many of these protocols are helpful. Again, today we're going to talk about the RUSH exam, rapid ultrasound for shock and hypotension protocol. This breaks it down into the pump, which is the cardiac evaluation, the tank, which is the volume status, and the pipes, which is the circulatory system. The pump, the questions you're going to ask yourself is how is the heart contracting, good or bad? Is there a pericardial effusion? Is the right ventricle enlarged? For the tank or the volume status, you're thinking, is your tank full or is it empty? Some things you can look at is the IVC large and does it collapse? Leakiness, is there fluid in the abdomen or lungs? Compromise, is there a pneumothorax? And the pipes, is the aorta enlarged or is there a DVT or deep vein thrombosis? This is where you would do those imaging. I often start off with the cardiac view, here in one, parasternal long and short, followed by an apical and a subxiphoid. Then you could move on to the FAST exam, which would be the right upper quadrant, left upper quadrant bladder views, an aorta exam, and then ending with a pneumothorax evaluation at points 8 and 9. So again, these are the three questions. So going through each one, the first one is, how is the heart contracting, good or bad? This is a parasternal short axis view. You see the left ventricle is a circular structure right here, and you see that there's poor endocardial excursion and poor myocardial thickening. This patient's in cardiogenic shock. Is there a pericardial effusion? This is a subxiphoid view with a large pericardial effusion right here. It's a subxiphoid, well, it's supposed to be a 4-chamber view, but you will really only see 3 because that right ventricle is so collapsed right here that it's having trouble filling in diastole because you have tamponade. This is an apical 4-chamber view, LV-RV, LA-RA. You can see that the RV is actually larger than the left ventricle, so it's significantly dilated with poor function concerning for right ventricular failure. Going on to the tank, fullness of the tank. Is the IVC large and does it collapse? The IVC is most helpful at the extreme. So in emergency medicine, we always say, is it fat or is it flat? If you look at the literature, I think a good number that I like to teach is that if the IVC diameter is less than 1.5, the patient is likely going to be fluid responsive, and you can say that the tank is not full. This is my favorite point-of-care ultrasound fluid resuscitation guide. It lists your IVC into different sizes. So again, it says normal is 1.5 to 2.5. So we said it's most helpful when it's fat or flat. So fat, we're going to call underfilled. We're going to say the IVC is less than 1.5 centimeters. If it's less than 1.5 centimeters, you can pretty confidently say that if you fluid resuscitate your patient, their hypotension will improve at least somewhat. If it's distended, we're going to call fat greater than 2.5 centimeters. And if we do that, we say there are, of course, exceptions, such as tamponade, pulmonary edema from other reasons, but we're going to say we're more likely going to fluid restrict and focus on our vasopressors and inotropic agents. In this normal range, most of the time, I'm actually looking to lung ultrasound for A lines and B lines to decide the next best step. The next step is going to be leakiness. Is there fluid in the abdomen or lungs? This is going to be completing that FAST exam, which is the right upper quadrant, left upper quadrant, and bladder views to look for bleeding. For compromise of the tank, we're often looking for a pneumothorax. This is a picture right here where you see the visceral and parietal pleura, and you do not see lung sliding. Lung sliding is going to be that shimmering at the visceral and parietal pleura that tells you that they are well approximated because the ultrasound is able to sense that movement at the visceral and parietal pleura. So here we do not see lung sliding, which is concerning for a pneumothorax, possible pneumothorax. Here is if you put M mode or motion mode, it will do motion over time along your ultrasound. And here on the left, you can see what you would see if you had a pneumothorax. You would see, we call it a barcode or stratosphere sign. You see these straight lines both above and below the visceral and parietal pleura. That says that something is separating the visceral and parietal pleura. It can be a pneumothorax or it could be something else that's separating. Versus here on the left, for a normal lung in M mode, we see no wall motion at the top and positive wall motion at the bottom, which is our seashore sign that rules out a pneumothorax. Next question is the aorta enlarged? This is a picture of a 5-centimeter aneurysm containing a mural thrombus. And then lastly, is there a DVT or a deep vein thrombosis? In POCUS, we do what we call the 2-point exam, the 2 points being near the femoral vein and the popliteal vein. But as you can see here in the femoral vein, even though it's the femoral area, we actually do multiple points because at each takeoff or bifurcation of the veins, that's where the flow is going to be most turbulent and you're worried about having a clot at that location. All right, now that we've talked about POCUS and hypotension, let's move on to POCUS and cardiac arrest. So POCUS and cardiac arrest is helpful to identify potentially reversible causes of cardiac arrest. The things we're often looking for are cardiac tamponade, pulmonary embolism, hypovolemia, and tension pneumothorax. With POCUS and cardiac arrest, we can also differentiate true PEA, or pulseless electrical activity, from pseudo-PEA. So pseudo-PEA is when you're going to, on ultrasound, actually visualize some cardiac motion, but it's in the absence of a palpable pulse. And the literature would suggest that the presence of cardiac activity on ultrasound, or pseudo-PEA, has a higher likelihood of achieving ROSC, or return of spontaneous circulation. If we do POCUS and cardiac arrest, it must be done rapidly. It needs to be done within the 10-second pulse check, and we don't want to let POCUS compromise our high-quality CPR. Here's a list of the H's and T's for evaluating the causes of PEA and cardiac arrest. So again, remember, hypovolemia, tamponade, tension pneumothorax, and thrombosis can be diagnosed with POCUS and likely change management. So here again, we have pneumothorax, we have a M mode across the visceral and parietal pleura showing the barcode or stratosphere sign. Here is an IVC dumping into the heart. This is in body mode. The indicator's on the opposite side, but we have a small and collapsing IVC. Here we have a subxiphoid 4-chamber view with an RV that's collapsed, showing RV diastolic inversion, concerning for tamponade. And here's an apical 4-chamber where the right ventricle is enlarged. So I did mention that pseudo-PEA is associated with better outcomes, but one study in the American Journal of Emergency Medicine did show that 8 out of 10 with cardiac activity had ROSC, versus 0 out of 23 without cardiac activity did not have ROSC. So again, this would suggest that the presence of cardiac activity has a higher likelihood of ROSC. However, the 2020 ASA guidelines have said that they suggest against the use of point-of-care ultrasound for prognostication during CPR, but they do say it does not preclude the use of ultrasound to identify potentially reversible causes of cardiac arrest or to detect ROSC, return of spontaneous circulation. That being said, when they go on to talk about knowledge gaps in this same 2020 AHA guidelines on cardiac arrest, they state, does the use of point-of-care ultrasound during cardiac arrest improve outcomes? Which is a great question that unfortunately, ideally, we would have some more literature on before clearly saying. However, if you know Dr. Josh Zimmerman from the University of Utah, if you don't, look him up. He's wonderful. And he always says, if you don't look, you don't know. I find it hard that I could complete a pericardiocentesis and get ROSC on a patient if I didn't actually do the ultrasound to see the tamponade in the first place to treat the patient. So going on, let's talk about how ultrasound during cardiac arrest or in hypotension can alter management. This is a study called the Focused Echocardiographic Evaluation and Life Support and Peri-Resuscitation of Emergency Patients. It's a prospective trial. They had 204 patients. They underwent the FEEL exam, so that's one of our POCUS protocols that we listed at the beginning. 100 of them were in cardiac arrest, and 104 were in a shock state. 96% had images of diagnostic quality. I would say that's positive. We can do this. We can get images that will make a difference. Mostly the subxiphoid view was used. They concluded that 78% of the cases, the echocardiographic findings altered management. And I found that it was really interesting that they had a cardiac subset where they found hemodynamically significant pericardial effusions in 13% of the pseudo-PEA patients and 8% in asystole. Moving on, this is a case series of anesthesiology resident performed ultrasounds. After limited training, they only had 4 days of training. They completed this ultrasound pre, post, and during cardiac arrest, depending on the clinical scenario. And this was completed by our only Dr. Bugrara, who is the creator of the Easy ALS protocol. And I'd like to draw your attention to some of the findings and changes in management that occurred. So in this patient, they found hypovolemia. They had started an IV fluid bolus and initiated massive transfusion. And as you can see here, this was a patient in PEA arrest. And while the patient may not have survived, they did get ROSC after their interventions. These two patients, they found on their ultrasound RV dilation and an underfilled LV. One was pre-arrest and the other was in PEA. And both of them, they were able to treat accordingly by stopping maintenance IV fluids, starting on vasopressin and milrinone in one case, vasopressin and epinephrine in the other. And the one that was in cardiac arrest, they achieved ROSC, and both patients survived a hospital discharge. Here's another case showing SAM, or systolic anterior motion of the mitral valve, on a pre-arrest patient, and they stopped the inotropes, started IV fluids and phenylephrine, and the patient did not arrest and went on to survive a hospital discharge. Now that I've hopefully convinced you that POCUS is very important during cardiac arrest, let's talk about how to implement it. Here is a subxiphoid 4-chamber view. I recommend you use the overhand hold indicator towards the patient's left side, and you should see RV, LV, RA, LA in the subcostal 4-chamber view, which is the easiest, I think, initial imaging on your pulse check. This is a subxiphoid IVC view where the ultrasound probe has been rotated with the indicator towards the patient's head, and you see the IVC dumping into the right atrium here. Here's the Easy ALS protocol algorithm. So again, it starts with 2 minutes of high-quality CPR. And as you note, during each pulse check, which should be 10 seconds or less, you will do simultaneously a rhythm check, the Easy ALS ultrasound, and then a pulse check with ideally an arterial live waveform and end-tidal CO2. Then, based on your ultrasound, you can look for reversible causes. And I like over here noting that if you get ROSC, you can also continue your ultrasound evaluation and evaluate for further, more advanced things such as regional wall motion abnormalities and possibly needing to go to the cath lab. So the Easy ALS protocol implementation has 3 stages. One is preparation. Again, you're going to perform initially 2 minutes of high-quality CPR, And you're going to announce so that everybody knows we are going to do an echocardiogram during the next pulse check. You're going to, of course, want to prepare the patient by removing any barriers, prepare your ultrasound, have the right probe, have gel on the probe, be ready to hit record. The second step is going to be execution. So you're going to quickly place the probe on the patient and announce that the pulse check and echocardiographic examination will be done in 10 seconds. It's really important that someone count down to 10 seconds, and ideally it's not the person doing the ultrasound. So they should count backwards, and you should tell them, please, when it's 10 seconds, make sure I stop, because we don't want to interrupt our high-quality CPR. We want to perform and record the echocardiography exam while they are counting down, and then immediately resume compressions. And when we're doing it, we want to hit record on our machine so that we can record our images. And then it's recommended that the interpretation of these images be done as CPR is resumed, so that you can focus separately on obtaining the images and then stepping back and actually interpreting from your video that you recorded. So you're going to resume the compressions and then interpret your images during the continuation of ACLS. And here's video.
Hey, can you hear me? Can you hear me? There is no carotid pulse. Sinus tach on the monitor. Hey, Sean, can you start chest compression? Hey, Mike, can you call for help? Get AED and the code card? Sure. Lynn, can you help with the airway? It looks like we're in the PEA algorithm. What cycle is this?
Starts here, starting 5.
In 10 seconds, we will check for pulse, rhythm, and we'll get a field exam. Eric, can you break the echo?
Coming with the ultrasound.
1 milligram of epi, please.
Yeah.
All right, 10,
Epi's in.
9, 8, 7, 6, 5, 4, 3, 2, 1,
Okay, acquiring images.
8, 7, 6, 5, 4, 3, 2. Resume chest compressions.
No pulse. Okay, there's no pericardial fusion. RV's moving well. He looks grossly underfilled. I think he's hypovolemic.
Hey Mike, can you grab a bag of saline and 1 milligram of epi?
Sure.
Hey.
So again, the EasyALS protocol interpretation, we're looking for reversible causes of cardiac arrest that we can find with our ultrasound. So pericardial tamponade, we will see a large pericardial effusion, a dilated IVC. For massive PE, you'll see a dilated right heart, a plethoric IVC, massive MI, a dilated heart, likely also a dilated IVC as well. Underfilled heart, hypovolemia, you'll see a small cavity and a smaller flat IVC, and then tension pneumothorax, no lung sliding, a lung point, and plethoric IVC, and tamponade physiology is another. You can find a large pleural effusion as well. So topics that we discussed were protocols and point-of-care ultrasound. We discussed the rush exam or rapid ultrasound for shock and hypotension, POCUS and cardiac arrest. And we reviewed the EasyALS protocol, echocardiographic assessment using subxiphoid only view and advanced life support, specifically looking for cardiac tamponade, pulmonary embolism, hypovolemia, and tension pneumothorax. And always remember, don't let POCUS compromise high-quality CPR. And I have educational videos on my YouTube account if you want to scan it. Feel free.
Thank you so much, Dr. Kadar. We really appreciate that. I'm going to maybe save the questions for the end, and we can kind of accumulate them for all of our speakers. Our next speaker is Dr. Kunal Karamchandani. He's a professor of anesthesiology and critical care medicine, a Texan, a fellow Texan, here at UT Southwestern Medical Center in Dallas, not here, but in Dallas. And we're super excited to have him speak today. Thank you.
All right, good afternoon, everybody. Let me see if I can get back to the original screen. All right, thank you, Sarah, for the kind introduction. Now, as part of the session where we're talking about the use of POCUS during medical emergencies, I'm going to specifically talk about its use during the management of a physiologically difficult airway. I have no disclosures and no conflicts of interest related to this talk. So we'll start off with some discussion on what exactly is a physiologically difficult airway. We'll talk about patient optimization and then the role of POCUS in patient optimization. And we'll end with something like what Rachel did, talk about Easy PDA, where we integrate Easy into the regular management of emergency airways in critically ill patients. Now, tracheal intubation is perhaps the most commonly performed procedure, in these ICU patients. And as you can see in the slide here, there's a bunch of complications that can happen with this procedure, and all of them eventually lead to poor outcomes. One of the largest trials that looked at tracheal intubation in critically ill patients was the INTUBE study published in JAMA in 2021. This was a prospective observational study, had about 3,000 patients spread across the world. Now, what they found was that about 50% of these patients have some kind of an adverse peri-intubation event. Cardiovascular instability was the most common in about 43%, followed by hypoxemia in about 10%. Now, interestingly, anatomic difficulty, which they defined as more than 2 attempts, was only 4.5% as compared to the 43% with cardiovascular instability. Now, if you look at the Kaplan-Meier curves here, the mortality differed significantly between patients who had an adverse event versus those that did not. Now, another study, the INTUPRO study, again, a very similar design, prospective observational study, this time from Spanish ICUs, about 2,000 patients. The results were similar. About 40% of these patients had at least one adverse peri-intubation event. Cardiovascular instability was again the most common, not as much as what we saw in INTUBE, but still pretty significant. Severe hypoxemia was 20%, almost double of what we saw in INTUBE, and that's perhaps because they included patients with COVID as well. Now again, look at the difficult airway. That was about 12%. Now their criteria was different. Anyone who had a past difficult airway, they included in that assessment. The results with regards to mortality were similar. Patients who had an adverse event were more likely to die. Now, traditionally, difficult airway management has been confined to anatomic difficulties, where you have difficulty with mask ventilation, difficulty with visualizing the glottic opening, difficulty with placement of tracheal tube past the vocal cords. But as we saw in the last 2 studies, especially in these critically ill patients, you can have poor patient outcome despite there being no anatomic difficulty. Let me give you an example. So this is a 57-year-old gentleman, weighs about 100 kilos, BMI of 35, who is in the MICU with acute hypoxic respiratory failure. And again, they call the anesthesia team to help with tracheal intubation. So you go in, evaluate the patient, and most of these patients are delirious, uncooperative. This patient's already on BiPAP, an IPAP of about 20, EPAP of 10, 100% FiO2. Now, in these high settings, he's barely saturating anywhere between 88 to 92%. He's tachypnic with respiratory rate in the 40s. You look at his vitals. He's tachycardic, of course, but his blood pressure is maintained, right? It's 140 by 80, measured non-invasively. So you decide to give 0.2 milligrams of etomidate and 1 milligram per kilo of succinylcholine. You do a rapid sequence intubation, put the video laryngoscope in. This is what you see. It's an easy view, right? You get the tube in, you see waveform capnography, all is well. Now you're about to leave and the patient's next blood pressure cycles to 80 by 40. End tidal, which was 30, now drops down to 15. Again, we're all anesthesiologists. We carry a syringe of phenylephrine with us. We push 200 mics. Nothing happens. Patient becomes pulseless and ACLS is initiated. So this essentially is what is a physiologically difficult airway, wherein the tube went in fine, but the patient did have a cardiovascular collapse. Now, the term physiologically difficult airway was first described by Jared and John Sakels in 2015. What they said was an airway in which the patient's physiologic derangements place the patient at a higher risk of cardiovascular collapse with intubation and conversion to positive pressure ventilation is a physiologically difficult airway. We published the results of our international Delphi last year, and what we wanted to change it to based on the expert opinion was that it's not just the pathophysiological alterations, things like hypoxemia, hypotension, severe metabolic acidosis, RV failure that Jared had described, but in addition, physiologic changes such as pregnancy, such as obesity, that also might predispose these patients to not just the cardiovascular collapse, but complications in general with the process of tracheal intubation. So now that we've seen that tracheal intubation in these patients is associated with worse outcomes, how can we improve these outcomes? So I think it's important to optimize the team and the patient both. Now, optimizing team is probably beyond the scope of this talk, but we'll talk about patient optimization, specifically hemodynamic and respiratory optimization, and see how POCUS might play a role there. Now, let's see what is the evidence available to us regarding optimization? Can we do this? So let's talk about hemodynamic optimization to begin with. What are the options that we have? We can give IV fluids preemptively, we can give vasopressors or inotropes, or we can choose a sedative hypnotic to get them off to sleep, judiciously. So let's see what data is available to us. Let's talk about fluids. So PREPARE was a multi-center, unblinded, randomized trial that was conducted to ask that question, whether if we give 500 cc's of fluid bolus before tracheal intubation, does that improve outcomes? Now, if you look at the results here, it did not do anything, right? So when the authors did a subgroup analysis, they saw that patients who were receiving positive pressure ventilation probably might benefit from this fluid bolus. So the same group then decided to do the PREPARE 2 trial, where they said we're going to only look at patients who are receiving positive pressure ventilation, and let's see if we give them a 500 cc fluid bolus, does that make any impact? And again, if you look at the results here, there was no difference in outcome between the group that got that fluid bolus versus the one that did not. So what it means is just giving fluids to everybody may not be helpful. What about vasopressors? Now, there's no randomized controlled trials looking at this yet. The one that came to my attention was this secondary analysis of the PREPARE 2 and the BUJI trial, which looked at peri-intubation hypotension in patients that received prophylactic vasopressors versus those that did not. Again, they did not show any difference in outcomes based on this propensity matched analysis. Now, there are two large studies, FLUA coming out of India and Prevention coming out of Italy. Vincenzo is running that. So we'll see if these results can help us determine which patients would benefit from these vasopressors. Coming on to choice of induction drugs, again, we have a bunch of options available to us. Propofol is our favorite. It's the most used drug for tracheal intubation across the world. But when they looked at the intube subset, they found that the use of propofol was an independent predictor of hemodynamic instability in these critically ill patients. So again, propofol may not be the ideal drug. What about etomidate? What about ketamine? Again, the data is pretty, conflicting in this regard. Kera came out, said there's no difference between outcomes. Then EVK was done, which was published in 2023. It said at 7 days, ketamine had better outcomes, but at 28 days, there was no difference. Bunch of meta-analysis as well, but we don't know which one's better. With regards to ketofol and propodate, again, there's unclear and limited evidence to suggest its use. So now in this setting, we want to optimize this patient's hemodynamics, but we don't know what to do. Fluids don't help. Vasopressors may not help, and we don't know which induction agent to use. So maybe this is where POCUS can help us. So let's look at some clinical examples. Let's start with the hemodynamic example. So a similar, we'll talk about the same patient or a similar patient. All these patients have kind of a same physiology. So this is the patient that you've been called for to intubate, right? So you go in, you put in the POCUS probe and see this in your parasternal long axis view. So let's see if it works. Now, as Rachel had talked about, that right ventricle is collapsing. This is cardiac tamponade, right? If you went ahead and pushed your induction drugs and tried to intubate this patient without taking care of this, imagine the hemodynamic collapse that would lead to. So again, it would make sense to do some kind of a pericardiocentesis or pericardial window before we start going along with the procedure. Let's look at another scenario. A similar patient, you're called to intubate this patient, you put in your probe, look at the parasternal long axis view, and this is what you see. That LV is not moving at all, right? Again, in this patient, if you had gone ahead, pushed in that 100 or 200 milligrams of propofol, imagine the cardiovascular collapse that would have occurred. So this patient has severe LV dysfunction. Again, what you can do is ask them to start a norepi drip. Ask them to start some inotropic support so that that ventricle is helped as you're trying to intubate this patient. All right, another example. So again, a parasternal long axis view. Let's see what this shows. Now this is a hyperdynamic left ventricle, right? And then you look at the IVC, it's collapsing. This is that patient probably in that PREPARE trial that would have benefited from that 500 cc fluid bolus because this patient is hypovolemic. Now, we wouldn't have known that till we put in the probe and figure out what's happening with the heart. Let's look at one more example. I think this is something that Rachel had talked about as well. So if you have a similar patient, now you're looking at an apical 4-chamber view. This is what you see. That RV is not moving at all. It's dilated, right? This patient has severe RV dysfunction. Again, pushing propofol, pushing etomidate in this patient, and trying to intubate this patient without addressing this problem would have led to catastrophic hemodynamic collapse. So maybe you want to make sure you have some pulmonary vasodi. If you saw this, I would put them on nitric or PDE, whichever you have at your hospital. Start them on some inotropic support to help the RV before you even think about intubating this patient. So what we've seen for cardiovascular part is that if you use POCUS, then it can tell you the cardiac function, both left and right. It can tell you fluid responsiveness, and then maybe you can tailor your plans, give some fluids, add some inotropes, vasopressors, and maybe choose your induction agent and the dose appropriately. Let's look at a few respiratory examples. I think Rachel talked about these for for undifferentiated shock states as well. But this is a patient that similar patient and a hypoxic patient that you want to intubate. You do a lung exam and this is what you see, right? This is a lung point. Patient has pneumothorax. There's two problems here, right? One is maybe this pneumothorax is the reason why this patient is in respiratory distress. And if you address this, you may not have to intubate. The second thing is, imagine if you miss this. You intubate this patient, put them on positive pressure ventilation, and pretty soon this patient has tension pneumothorax and has a hemodynamic collapse. So again, POCUS can save the day if you try to do it before you go ahead and intubate this patient. Let's look at one last example. So now this is a MICU patient desaturating to the 70s. You look at the chest x-ray, has diffuse bilateral infiltrates, right? You put in your probe, you see a bunch of B lines here. This patient probably has severe ARDS, right? So what do we want to do different in this patient if we know that this patient has severe ARDS? Maybe use non-invasive ventilation for pre-oxygenation. We talked about this. When these patients who are critically ill, hypoxic, if you want to intubate them and bring up a reserve, a lot of them with severe ARDS might need non-invasive ventilation for pre-oxygenation. Maybe not for all, but if you saw this image, you saw those chest x-ray, you might want to call for non-invasive ventilation for pre-oxygenation. Now, POCUS can also help prevent gastric aspiration. Again, you go in, you do a gastric exam, this is what you see. Again, if you have the option to drain this gastric fluid, it might prevent aspiration. So we published this algorithm a few years back. I think it combines the RUSH protocol that Rachel had talked about. But the message that I want to convey here is if you have the feasibility and the options, try to use POCUS before these emergency tracheal intubations in critically ill patients. Now, at the end, let's talk a little bit about easy PDA. Just like Rachel talked about easy ALS, let's see if we can integrate easy into the management of a physiologically difficult airway. I don't think I have to explain this slide anymore because Rachel already talked about what easy is. But what we did was we tried to integrate this easy protocol, which involves the subxiphoid echocardiographic view, along with some lung and gastric ultrasound before going through this emergency airway management. This was a retrospective single-center feasibility study. Again, all tracheal intubations occurring outside the OR. These were trained anesthesiology residents. And Nibras is going to spend the next 15 minutes talking about how do we train people to do this exam. They were asked to fill form, identify clusters. Again, Rachel talked about these clusters already, so I'm not going to go into detail. So what we did was we found 30 patients. And when we looked at the time, it was only 2.5 minutes. This was the time that was being taken to set up the ventilator, set up the drugs, get the airway equipment ready, and so on. And as Rachel had mentioned, POCUS should not be limiting patient care. So we were able to show that it takes only 2.5 minutes, the same amount of time as it takes setting up things, that someone can do this POCUS. Now, interestingly, in about 90% of the patients, this POCUS exam was able to inform management. One patient ended up getting a pericardial window. 2 patients ended up getting gastric decompression. All right. So in conclusion, What I want to highlight is when you go about doing tracheal intubations in critically ill patients, don't just think about the anatomically difficult airway. Also think about the physiologically difficult airway. The tube might go in easy, but that's not the only thing we want to worry about. We want to worry about patient outcomes. Patient and team optimization is the key. We didn't talk about team optimization, but I hope I was able to convince you that if you have the capabilities, POCUS can definitely help you with patient optimization, hemodynamic, respiratory, as well as preventing aspiration risk. And I think it's important to integrate this into our regular workflow, and with easy PDA, we were able to show that this can be done. That study should be published soon. It's been accepted. It should come out in Critical Care Exploration soon. Thank you so much for your time.
Thank you so much, Dr. Karam Chandani. That was an excellent talk. And I think, I'm sure we're going to have a number of different questions. I sure have some for the group. But our next presenter, Dr. Nibras Bugrara, whose name you've heard mentioned several times, is a professor and vice chair of education for the Department of Anesthesiology and Critical Care Medicine at Albany Medical College. And he's going to kind of talk with us a little bit more about how practically to incorporate these components that you've heard into your workflow as an anesthesiologist. Dr. Bugrara, thank you.
Thank you so much for this wonderful introduction. So I have a lot of slides, so I'm going to start right away. Objectives is to talk about how to train the residents on obtaining point-of-care ultrasound in a safe way, and talk about the role of simulation and AI. So why we use ultrasound in cardiac arrest, I think we all know.
Yeah, there's a pulse. I don't have a pulse. That's good. Look right at that. That's a pulse, right?
That's your pulse.
Fully different pulse, man. Really?
Don't know what you're talking about.
This is a pulse.
You know what? I'm ready to go for this.
I'm ready you up for this.
There's no pulse.
All right, so we all know from medical school that cardiac output is heart rate times stroke volume, and PEA stroke volume is 0, but have you thought about if there's a small stroke volume that you cannot palpate, and this could be called a pseudo-PEA, which could be due to many causes, maybe pericardial tamponade, maybe a massive MI, tension pneumothorax, big clot in the lung, or hemorrhagic or hypovolemic shock, and if you apply the ultrasound probe 2 centimeters below the xiphoid process, utilize the liver to transmit the ultrasound waves, you can have a look at the long axis of the heart along with the pericardium. So you can diagnose if there is any pericardial effusion or tamponade. You can see the size of the RV in relation to the LV. You can see the squeeze. So it doesn't take a lot of time. And Rachel showed us that we can do it in less than 10 seconds. So we took echocardiography from the traditional too many views, needs a lot of training, expensive machines, to now the FATE exam, which is published in 2004, which now reduced all these images to only the subcostal, the apical, and parasternal views. And it shows that after a short training, the intensivists were able to get views in 97% of the time. And then there's another study in 2005 compared medical students with handheld ultrasound to cardiac attending anesthesiologists, cardiologists who are board certified. And believe it or not, the medical students outperformed the cardiologists in every domain. So we know that ultrasound is really easy to obtain right now, and the machines are very small. You can even, if you have the nostalgic place around the neck, you can do the same with the ultrasound new probes, and the image quality is really good. So this is great. There are too many courses to teach ultrasound. But this is my son obtaining the subcostal for chamber view. So you can go get the course and learn how to use ultrasound, but there are a few precautions.
Roll your palms together. So both your hands are going to sit on the left-hand side of the pistol. You're going to walk out. Hold your arms. You're going to push with your right, pull with your left. Focus on that front side tip. Now, if you want to, on this 44 Magnum, you can shoot it single action. Did you mean to do that? Yeah.
So have you heard about the Dunning-Kruger effect? So in the beginning, when you learn a new skill, you think that you know it all. And then after some time, you start realizing that, wait, there's a lot that I don't know. And with time, you're going to obtain more skills. So initially, you can see that the confidence is falsely elevated, which is very dangerous. And then it takes some time to get back to the expert level, which is still a problem. For this reason, the top 10 2020 health technology hazards was named by the Emergency Care Research Institute as POCUS. And this is because there's a lack of sufficient oversight and training. And these are all the possible problems. For instance, POCUS is not used when it needs to be used or used inappropriately. The right question wasn't asked, misdiagnosis, variation in training. So I'm going to show you how we try to overcome all these in Albany Med. Finished my critical care training, fellowship, and critical care echocardiography, and then joined Albany Med in 2015. Started by altering the atmosphere, the political atmosphere, gave a grand round to talk about the FATE exam, and I was able to convince my chair to give me $12,000 to buy a probe. This was our first, we got a cardiac probe for the ultrasound machine that we own already. So we started by giving a physical multiple choice question exam to all the residents. And this guy was cheating, he was carrying hard. Anyways, we did then, after that, we tested them, we did 1-day workshop. But do you think like 1 day is enough? I mean, the Society of Critical Care Medicine said you need to have at least 20 hours of lectures and then 30 exams performed and 50 interpretations. Can you fit this in 1 day? No. So we designed a 4-day course. We utilized the Society of Critical Care Medicine videos. They have around like 10 hours of videos that they publish every year. And we utilize these videos to train our residents. So we moderate the lectures in the morning where the residents will watch the videos, but we allow time to pause and have question and answers. This is one of the residents getting picked to show how to calculate stroke volume at one of the lectures. And then we do go and scan 5 patients per day in the ICU, which equals to around 400 minutes of scanning, supervised scanning time. Then we test them. So we want to see if they're competent or no. So we basically have a Delphi approved study where we're looking at whether they choose the right position for the patient, whether they applied all the, if they obtained the views very well. So it's a very vigorous process, and then we test them. And then 6 months later, another test to see retention. And we showed that in 4 days of training, we were able to maintain the passing score was 70%. All these years, they were really getting above 70%. And what was surprising is in 6 months, they were maintaining the score. So they maintained their knowledge after 4 days. And then in 2020, something bad happened. So yeah, I mean, we were very overwhelmed with all the cases we got, so we couldn't really allocate 400 minutes to supervise the residents. At that time, one of the companies gave us an ultrasound machine to test it for them. It utilizes AI, more than 5 million images, to actually give 2 things. It guides the sonographer how to get the view, but it also gives an image quality assessment. So what we did is we utilized this in our workshop from then, where we had the residents, we just supervised them to do 2 patients examination. So we teach them how to use the AI, and then we ask them to only save the images where they get an image quality more than 80%. So I don't have to review all their images. And then we did a test after that, and then, so they watched the videos with less supervision. And what happened is, at the end of the course, they passed with much less than with much less effort of training, and they passed. They get the 70%. They didn't get a lot of retention, but only 6 months later, they have lower retention, but it was still significant. So what we did is we changed our way we're training our residents now. And we do a workshop at the beginning of the year for 3 days where we actually go over the lectures and then train everybody how to utilize the AI. This way, I give them then a month where they have to procure 20 exams without direct supervision. But they shouldn't save any image if the quality is less than 20%. So this is like a medical student obtaining an image during the workshop, and she was able to get a 99%. See the scoring right here. 92. All right.
You see my 99?
You got 99?
I did.
Are you
I don't know
a
if it's right
doctor?
now. No, I'm not.
So now with AI, we're able to show that probably we can overcome some of the limitations. Training simplification, AI-powered assistant in standardization of the image quality assessment, and it was helpful. But still, it's a 3-day course. So what we did also, we did a notice that a lot of times during emergencies, you only need to see the phenotype of the heart. You don't need a lot of imaging and angles to tell that this ventricle is thick and empty, which correlates here to this phenotype, which we know that if you have a flat IVC and thick LV, is probably diastolic dysfunction and hypovolemia. So, and then we developed these cards for management to separate the phenotypes and try to do the training based on these phenotypes to see if we can train the residents in one day and see if we can get results. So basically it starts by
Okay, go ahead.
having the residents obtain the image, supervised, no interpretation. They just need to get the subcostal 4-chamber, followed by IVC. All right, show me the aorta. Then we see the aorta because it's difficult to differentiate between both. Then there's a subcostal short axis view. And we end by looking at the lungs. So all the images are obtained and saved. See if there's A line, B line. After that, we just go outside the room, we use the phenotype cards, and we try to see how we assess the image quality together. And utilizing the cards, the phenotype cards, it was easier to start explaining all these differences of phenotypes to the residents.
Normal in size, but there was hypertrophy. We had very good image quality. So this would probably be closer to a phenotype 3, the left ventricular hypertrophy. We also had the plethoric IVC, and then
So discussion about image quality and interpretation happens outside the patient bedroom or the room. So it doesn't happen during. So this forced the residents to save the images, because if they don't save the image, there's no interpretation. These are the phenotypes. Basically, the yellow cluster is when there's a good ventricular function. The blue cluster correlates to pump failure when the LV is not squeezing well, severe left ventricular dysfunction. And then the red is severe isolated RV systolic dysfunction and dilation, where the RV is bigger than the LV. And we developed these hemodynamic management cards. So for each hemodynamic phenotype or cluster, there's a specific card that we utilize. During COVID, what we did is we trained the surgery and anesthesia residents one day, where there's a couple of recorded lectures about the utilization of subcostal view. They watch it on their own. And then we have 1 hour of where they come in. We do discussion about the different phenotypes, and then we had them go in SICU in non-COVID patients and scan 10 patients for subcostal view. So image acquisition was obtained in one view. And after that, in the next day, they pre-scan the patients before rounds. So go to the room, close the door, wait for them to do the scan. And then based on that, we do the interpretation during rounds. So they save the images, and based on the images, we can basically separate these patients who are hemodynamically unstable into phenotypes where we can tailor management. So in this situation, there's lots of B lines, plethoric IVC. This is distributive shock. You shouldn't give fluid. You should give some norepinephrine. And the training the exam took around 4 minutes, and the training took around 1 day. So again, we separated the image acquisition from image interpretation. During the entire month, while we're rounding the ICU, we go and we talk about the interpretation for all these different images, and we utilize the phenotype cards to help. So what we did also, our colleagues in Libya, they were having the same problem. So what we did, we started rounds in the ICU where I gave them, and you can take a picture of this. This is the video lectures that we sent, and it's an entire course about how to utilize the subcostal view. So we did that online training where they watched the videos, and then we did some training where we basically, through the video phone call, we were training them how to get the subcostal view. And then we do the virtual rounds where every day they will send me the images. These are real cases. So they would go, okay, this patient has, through WhatsApp actually, they send this one small ventricles with flat IVC, and we gave fluid and norepinephrine. Patients have large RV compared to the LV with plethoric IVC, and these are the management cards. So we were able to do virtual rounds and help them manage their patients. Finally, we're able to do that course, and we got to start to utilize it to train our, like if you want to take the easy course, you can come, for instance, the next IRS meeting in Montreal, and we do the simulation and the training for the subcostal view. And these are the countries in the last 12 months we went to do the trainings. And I'm going to share with you my trip to Libya last year. This is the first simulation scenario we did with the team over there. So, horrible chest compressions. Taking forever to check a pulse. There's no board underneath the patient. Trying to scan on top of the barriers, putting the ultrasound on the dressing, trying to get a view. Like a lot of, so even the mannequin didn't make it. So we did a little bit of feedback. It was a very nice, everybody was smiling. We talked about all these mishaps. And then we did some training on how to do chest compressions with music, learn how to do that. And then after that, we did, this is the last simulation in the day. So now they're putting a board underneath the patient.
Improve compressions, please. Press them and dip. If you are tired, you can switch. 10 seconds till ultrasound. 3, 2, ultrasound, please. 10, 9.
There's a large thrombus in the right atrium.
Administer thrombolytics, please. Okay.
Now closed loop communication.
كان اكسلنت الله يعني انت حسيت قال انا بدي جديده وكان مركز على الدب وحتى لما واحد تعب يعني قال زيد الريت وزيد الدب.
So this was a 1-week effort course where we did 3 days training for train the trainers. So we trained the trainers, and these trainers ran the simulations. So when we left, these simulations are still going on. And this time the mannequin made it, so everybody was happy. So I think we're going out of time, but I just want to share with you that to really progress and avoid issues with point-of-care ultrasound training, you always need to save the images. So that's why in our institution, we don't interpret any live images. All images has to be saved and then looked at after. So we review the images, and then the ones that meet criteria, we send them to PACS, meet criteria for indication. The ones that we don't want to bill for or we don't want to use we keep it in a separate hard drive or separate cloud where we use it to count how many patients or how many scans each one of the residents done, and we can actually always review them. So we have all the scans done from 2015 till now saved. This is an example of how our rounds happen in the ICU now.
So here we're seeing, looks hyperdynamic and it looks a little flat.
Does it look like this?
Yeah.
No, let's look at the IVC.
So looking at the IVC here, it looks very flat.
Similar to this.
Yeah.
Then the upper lungs.
And then here we're seeing A lines. There's no B lines that we're seeing.
All right, similar to that. So we're gonna select this. The etiology is hypovolemia right here. So it was really helping in transferring information, transmitting information to residents.
Bedside POCUS pre-rounds. There's no pericardial effusion. Right ventricle.
Now the images are saved in QPath, so during rounds we can actually look at the entire examination during rounds.
So, IVC looks like it's full. Grab the view of the aorta just to verify that I wasn't looking at the aorta before. This right apical segment chest shows A line, this left chest, so A line's present. You can see a small amount of atelectasis in the lung. There's no dynamic air bronchograms. This is going to be the left lung here.
Complete
here,
physical examination,
diaphragm,
basically, without entering the room. Sometimes you get into
Not for that, but
biopsies
you
like.
notice this? What is this?
So it's not super clear what this was.
So now, anytime we're not sure about anything, then we go back to the room and then scan the patient to save the patient information. And
Oh my goodness.
this was a large clot that we just found during
Like
that.
a clot in the inferior vena cava.
And at the end of the year, each residents receive an evaluation, a letter to support to show exactly how many hours of training they receive, how many exams, actual exams they did, because everything is saved. And we would make sure to meet the criteria set by the Society of Critical Care Medicine for competency. And yeah, we're done.
Thank you so much. That was wonderful. Thank you so much. Well, I think we have about 5 minutes for questions. So if anyone has any questions, would they like to pop up to the microphone and ask? If not, I have a couple of questions while maybe we're waiting for folks to come up. So, Dr. Kadar, you had mentioned there was conflicting data in regards to using point-of-care ultrasound in cardiac arrest. You'd shown some that evidence to support it, others to not. And I would say just this last year, we published a guideline update through the Society of Critical Care Medicine. And one of the questions we asked was, is point-of-care ultrasound or critical care ultrasound useful in patients for cardiac arrest? And we looked at patient-important outcomes. And our recommendations was you could use it or you could not use it. That it wasn't really the data that's out there up until now, like you say, is conflicting. Why do you think that may be?
I think there's data to show that in many instances where it's used, the pulse checks are too long and that has negative patient outcomes. So I think that's one of the limitations and one of the reasons where it could harm patients. The other thing is it's user dependent, right? So I always say to my residents, if you can't answer your question, just don't. So, sometimes people will say, oh yeah, that looks okay. And I'm like, that's not diagnostic. That's not a diagnostic image. So I think it can be helpful when it's a clear diagnostic image and we do it within the 10-second pulse check. I think it's not helpful if we are guessing about what we're thinking or we're seeing, or if we take too long.
Thank you so much. Dr. Karam Chandani, my next question is for you. So I'm sure while you were talking, there were people out in this audience who said, well, we can't scan everybody who's in respiratory distress. I mean, if their stats 70%, we got to tube them, right? We can't wait. So what is your recommendation? Is there kind of an algorithm or a pathway that you go through in your mind to decide who is going to get that pre-intubation scan versus who is not?
So I think that's what Nibras showed us, right? That the data that I presented, it's only 30 patients. It took 2.5 minutes, right? So for example, you're an anesthesiologist in the OR, you get a page that this patient in the ICU needs to be intubated. Now, if it's a code, that's a different scenario. And then we go to easy ALS. If it's not a code, that means they want to intubate this patient is in distress. While they're setting it up, if you take your POCUS machine with you, if it takes only 2 minutes or so to look at those views, I think it's doable in everyone because it's hard to say. The scenarios can be same, but what you might see might be different, right? So I don't think we can selectively say that I want to scan this one and not this one. If we want to integrate this into our workflow, we should make it in such a way that it does not compromise patient care. So while you're a respiratory therapist, because when you go in, you ask them to draw up drugs, you ask them to get the airway box ready or whatever it is, it invariably takes more than 2 minutes to do that. So while that's happening, that person that you have that is trained in POCUS, as Nibras has shown how easy it is, maybe we'll take his son with us, but he can just look at that within those time and let us know what's happening. So again, I would not say that you can selectively pick and choose because then you might get burned.
Thank you.
I just want to add here, in our institution, we have the code team basically is the attending physician and CRNA who would do the intubation. And then if the resident is available, they would come in and they would help with the scanning while the CRNA is sitting for the intubation. And when there's only attending or CRNA, obviously the CRNA is getting ready and intubating. The attending will do the scan and then basically call off the medications used and then give the recommendations for tailoring management. So it's done in a way that it should not impede the progress.
And every place might have different ways they do things. I think, you cannot say this is how Nebraska does this is how we should be doing it. No, I think the premise is you want to integrate it into your workflow, but what your cultural situation is with the institution, what your personnel situation is, you should try to do that within those, parameters. Otherwise, you'll fight too many battles and it's not going to be worth it.
Well, and like you're alluding to, a lot of this is based on culture and training. And to kind of piggyback on that, just as a last question for you, Dr. Bugrara, we've been talking about point-of-care ultrasound forever. And yet still people are reluctant to pick up the probe and put it on a patient and do the scan. So what do you think after all this time? What's the biggest barrier? What's the thing that's kind of kept us back?
I think it's really the entry point. So if we're trying to make an entry point, which is complicated, where you have multiple views and you have to ascertain when the view could be used, what are the limitations of each view, and then the time investment for your exam to spend like 15 or 18 minutes trying to get all the views in every patient, this is going to be putting down any efforts to, even if you go to a workshop for 2 days, like the Astra workshops, the SSCM, when you come home, you're not going to bring it because it's long time where you're going to do it. It takes longer to do. There's a lot of things that you can misinterpret, and just learning these views and learning the pathology, knobology, pathophysiology is too much. So I think if we lower the entry point in a safe way where we focus in one view and show the pathologies that are really life-threatening, and then this way you learn your machine, you learn your knobology, you learn how to evaluate the image quality of one single view, and then I always time my residents, they have only 3 minutes to obtain the exam. If they don't get it, then we get the fellow or someone else who did critical care echocardiography to get more views. So I think it's really lowering the entry point in a safer way, having a structured approach where we save all the images so we can continuously give some feedback. And then maybe we should have like a team-based approach where not everybody should be an expert. Maybe the majority will learn how to do, for instance, the subcostal view, and then 20% will get the other views, and then you have the critical care certified attending who would be overseeing the entire process. So the one who's performing the procedure cannot do the interpretation without having a supervision or without having a mechanism to get feedback on his thing. The other thing is there's a lot of cultural issues, and what we battle the cultural issues, for instance, with the nurses to use ultrasound during cardiac arrest and physiological difficult airway. We start including them in our simulation, because before that we were getting a lot of pushback, and then we started doing the simulation. We invite, every time we do it, we invite 2 or 3 nurses, and then they felt like empowered. For instance, they have the power to stop the residents within 10 seconds. So if the resident's trying to get the image and it's more longer than 10 seconds, they have the power to say, okay, let's stop now. So there's a lot of problems, but I think one thing is having a structured approach where all the images were saved for QA, lowering the entry point in a safe way. I think these are probably what I start noticing, because right now application internationally is much more smoother for us than when we apply the full views. And I noticed that in all these countries I go, is when I come back the next year, I still see that they're being used. And because, as I said, it's a lowest investment. It's a very quick exam, and it's lower entry point. So yeah, that's what I think we should go.
Well, thank you. Thank you all so much for attending this afternoon, and thanks to our great speakers. Thank you so much.